So I think we are live, Julie.
It just says starting soon on LinkedIn.
Okay. It should actually already be live.
Okay. Tap to join, it says for me.
Okay, so let's start. So, how are you guys tonight? It should actually already be.
Sorry. We're good.
Yeah, I think we are a little bit delayed, so I'm really sorry. So you realized already our resilience boot camp in the beginning. So I think we're just LinkedIn has a bit a delay in sending it. So yeah, it's great to be here today, Petra and Julie. We talk about fear-free veterinary medicine. Oh, look here, people are there as well. Hi, Imke. Hi, Dina. Good. All right. Shall we start?
Good. Yes. Let's do.
Fantastic. So, guys, when I'm sometimes looking to the side, it's not because I'm working towards ignoring you. It's actually because I have two computers. I will share the picture. It's quite a scene. I feel like a DJ at the moment. So we first will remove Julie and then add this beautiful. Okay, let's start. Let's talk about fear-free veterinary medicine. And we have quite a bit. Do you want to run us through the agenda, Petra? Or
I thought Julie was going to do that, but I may be wrong.
Yeah, she's not. So why don't you start?
Okay, fine. Well, let's go through the agenda. So, yeah, just to give you a little bit of an idea of what's going to happen tonight, we're going to have a quick sort of intro and chat about what collaborative learning culture, collaborative learning culture might look like, and what psychological safety is. And we would like this to be really interactive, so please carry on popping things in the chat, your comments, your thoughts, questions, ideas. We'll then have a Q&A, and then Holger is going to dive into the collaborative learning culture a little bit more in depth, and he's going to share his experience. He's had at TIHO with his that's a Fila culture study. Was that well, I'm looking forward to what you've got to share. I think there's lots. You've had some hints. I had some hints.
Potted version. We do a potted version. Yeah.
And then I will come back to psychological safety a little bit and explore a bit more sort of how a collaborative learning environment might look particularly in small group settings, but also in general, I suppose, with in veterinary education. And then we're going to finish off with a final Q&A and exchanging ideas for best practice, where really I think both Holger and I, we would like to really invite you to bring your experiences as well and share your ideas, because we don't have all the answers. It's just really, this is a platform and an opportunity to discuss ideas from everybody. And then quick feedback at the end and ideas for future topics.
So you wanted to have some ground rules, but at the end of the day, let's be kind. Vicky Lipscomb, good friend of mine, she always said to me, there's always a reason to be kind. So I think that's only kind of the housekeeping, that we are nice to each other. Right, Petra?
Yes, I totally agree. So in that spirit, we would like to make this a kind space where people can learn together.
And we have quite a few Menti questions. So the first one is just scanning the QR code, and you all probably have done this in the past. And then obviously don't close your browser, because when we move on, I don't always have the QR code. And otherwise you can also type in menti.com and then the code which is always on the top of the slide as well for each slide. And the first question is, Peter, you put this question in. So which animal are you tonight? So after people have been voting, you have to tell me which animal you are.
I'm very happy to. This is just more or less a check that Mentimeter is working. So it would be great if you could try it out, even if you don't feel like anything in particular.
Yeah,
I'm currently seeing zeros, so that makes me worried it might not work.
No, it's just a little bit of a delay, you know, because it takes time. Oh, there's a lion. Ooh. Fantastic. Yeah,
lion,
there you
go.
I always wanted to be a giraffe, to be honest.
Really?
Yeah, there's a bit of a time delay. Yeah, it's just how it is.
Yeah.
You know?
There's a bit of a backstory to the lion and the panda, and the people who know me might be able to guess what that is, because I'm a big Ted Lasso fan. I don't know. Have you seen Ted Lasso, Holger?
No, sorry.
Honestly, it's the best series ever.
Okay.
It's really funny. It's about football and it isn't about football. Okay. Anyway, there's a line in there where somebody asked somebody, if you could choose, what would you rather be, a lion or a panda? And then the question is, who's
Okay, see, someone decided to be a lion.
Somebody decided to be a lion.
So fantastic. So thank you for being very participatory. And the next slide, no one wants to be a dog, which I don't understand.
I would have chosen dog. So
yeah, exactly. So the what and why of collaborative learning culture, and I wanted to start with this person, and I'm not sure if you guys know the person. Anyone? Because you guys are very intelligent people. So anyone has an idea who this is? And then because that's kind of why we all started with that. No one is posting yet. So this is Martin Bromley, and he is a British Airways pilot. And what happened to him is that his wife died after an anesthetic procedure. So she should have gone on a GA, and the anesthetist tried to intubate her and couldn't get her intubated. Tried with a smaller and couldn't get there. Then asked another anesthetist to join in and try to intubate her, and obviously they failed, and the person died. And the really sad story is that the theater nurse already had everything prepared for a track tube, but because of the hierarchical situation there, didn't dare to speak up, because she was just, when people said they want to do a procedure, then she would help them do that. And he obviously had a little bit of a battle with the NHS and went all through media. And making the story short, he was very shocked that there was no system really in place, like in the for pilots or in the airline industry, that you actually can look at a mistake happened or whatever it is, and then you have a systematic way of really working it up. And I know many people already know about human factors and so on. But I wanted to tell you also a story, and this was very shortly after I've been head of department. And I just put this in because I know that Julie loves horses. Petra, I actually don't know if you like horses or not, but this is me and my dad. You can probably know which time period this was, right? But this was little Sherry. And the only reason why I put it in there is to remind me to tell you a story about, I think it was 2 weeks since I was head of department, and a horse died because someone injected a medication in with a wrong application. It was an antibiotic through IV, and obviously this animal died. And what I found very interesting was suddenly there was a lot of finger pointing. Everyone was starting to point fingers, and people were saying, "Oh, this person," they were real blame culture. and no one was responsible for it or accountable for it. And what we did is we actually worked towards taking all the emotions out and looked at the process and looked how can we work this up systematically. And the interesting thing, and we have done this now multiple times, and we do this routinely, and I give you some examples later, that when you look at a medical error, it's often a concurrence of many steps before the Swiss cheese model, which we mentioned later. But what I was most shocked about is obviously something really terrible happened. Someone had to break the news to the owners. And what is more destroying than actually everyone pointing fingers when you did this mistake? Yes, one has to be accountable, but this one of those moments can destroy the future of any vet. And I think something we have quite commonly. That doesn't mean that every error is a big one, also small ones, obviously, but these are obviously the ones which remember. The one thing is there are obviously a couple of training sites, also emergency doctors in human medicine, but also there are some training possibility in the UK, also with some British Airways pilots, and also in other countries, also in Germany, there are some pilots who do some training, and they are great, right? And they get trained on different scenarios and do different tasks, and they also put you in a situation. For example, in this situation, we were asked to fly over the channel. I had a great pilot because I thought, hey, you are just a co-pilot. That's great. It's fantastic. And I had a really simple task. I had to say, the speed, the height, and the direction. And it was really simple. All those numbers I had to hear, when I was called as a plane, and I had a typical code for that. And it was really enough. I felt really proud because after a while it felt really second nature. And then guess what happened? Suddenly there was an emergency in the back. There was someone collapsing in front of the emergency exit, and suddenly I had to deal with a situation which took completely my focus of giving the pilot the direction and so on. And I learned very quickly that the first sense which goes away is hearing, which is something very common. And you will see that feature over and over when I later talk about error culture and what we found. It's always communication, just one of the key tasks we have. But then they trained me and gave me tasks and scenarios how I can overcome this. And we also discussed about how we can get other people involved. So what I was saying is that they are very specific in their training. It's not just about knowing which button to press and the knowledge and skill set, but the reflective art. However, and we will hopefully get into this more in-depth discussion, they fly one plane. They might be trained on two planes, but most of them fly one type of plane. They do this exact same procedure over and over again. It's very easy to standardize. And when you go through these systems, it's always, you realize that medicine is a lot more complex. So I think, yes, the airlines can teach us something. The industry definitely has a better safety culture, and there's really no death when you fly a plane, but we can also improve. So we came to this idea of looking at error culture more systematically, and how we can integrate this in our learning as clinicians, also with students, residents, and so on. And we got a bit of money, and it's obviously in German. So Fehlerkultur means just error culture in veterinary medicine. And the project is now coming to an end. And I will only give you later, after Petra gave some slides, what it's all about and what we found in the snippet. But there's multiple publications coming out. The great things on this error culture, and I had this research is always a collaborative approach. Saying this here, the people were amazing. They were really great. We have everyone is just chipping in. They're really working together, and I'm really proud of everyone. And it was a really great experience. And I'm a little bit sad that some of the team members are soon having their doctor thesis finish. And it was absolutely great the year we had. And I'm not sure.
That's not good.
how you guys feel, but when an error happens,
somebody will come.
Sometimes you get into the self-helplessness mode.
No. Sorry. Somebody. Hello. There are 2 people stuck on an escalator and we need help. Now, would somebody please do something? I don't believe this. You gotta be kidding me.
I'm gonna cry.
Well, there's nothing else left to do. That's it.
Hello. Hey, don't worry about it. I'll fix it in a second.
He said he can fix it. All right. All right. That's more like it. He says he can fix it.
And I'm sure all of us have been in these situations, right? And definitely when you're head of department, a lot of people come to your office and they always, and you're like, guys, just walk on, just go up those stairs, just do it, right? But we get stuck, and then we need someone who's kind enough but guides us to get and actually find a solution and walk on to find a solution for the problem. So how do we, on the one hand side, make it safe and give them the safety net? On the other hand side, get them from a beginner state, so being unconscious incompetent, to becoming conscious incompetent, because that's something which feels awkward, it feels hard. You reflect on yourself and then become conscious competent, unconscious competent. And the very difficult part of it is that, especially when you're a supervisor or a resident supervisor versus, diploma holder, for example, what happens is that you see, for example, a neurologist, I see the dog walking, like, there's a problem. And the beginner, on the other hand side, I have to explain him bits by bit, and they're not even aware what they don't know. So how do I get them actually to become conscious incompetent? It's not a simple thing. And it feels sometimes quite difficult, because suddenly you realize what you don't know, and a lot of people don't like this. But at the same time, we have to make it safe, that we don't overstretch them. And I'm really looking forward, and that's actually the whole reason why I agreed to do this talk, to get Petra's idea on that. So how do you get them out of the comfort zone, making sure when they get stuck in perhaps sometimes a learned self-helplessness mode, and then get them a little bit, because that's the thing, when you become conscious incompetent, there's a little bit of fear zone, and then you come into the learning zone and then the growth zone. But what you don't want to do is overwhelm them, and then they burn out. And I find this very difficult. And nowadays, where we are all aware about mental health and making sure that they are safe and so on, how do we still give them enough opportunity to learn and stretch them enough? And I'm really looking forward to your thoughts, because I'm definitely not knowing the 100% answer for that, but I'm looking for that. One thing, obviously, and everyone who works with me probably hates me for that, but I think it's a very good concept, is the growth minds theory, right? Saying that as well, you do experience people struggling constantly to reinventing themselves and starting to grow. But we do know, and that's one of the second reason. The first reason is to improve patient safety, improve veterinary medicine quality. But the other reason is we do have a big problem with mental health. We're a very caring profession. And is there a possibility, if we have a better error culture and get them also into a more growth mindset, and seeing that there's actually a benefit of learning from your errors, that we will have a more sustainable profession? And this is just one example now in students, where they have shown that there's a certain growth mindset. And we looked at that as well in our students, can actually protect you from certain things. One of the ideas is that, for example, that as more flexible you are, when you do sports, and can you get actually, you will have less harm. So as more flexible, you will less harm. But on the other hand side, can we get the same resilience training in your brain, getting you always to flex your muscle of your brain, also to make you more protected of burning out problems. So what is a collaborative learning culture? A collaborative learning culture is an environment where you actually feel engaged, you're active, you share your knowledge, you don't keep your knowledge to yourself, you have an idea exchange on a level basis, and we have a common goal. And that's actually quite simple in veterinary medicine if you think about it, because we all have the common goal to improve patient care and help the stakeholders, the owners, the pet parents. And we do need to have an open communication, trust, accountability. We'll talk about this later a little bit more in detail. And we do also have, on the one hand side, and that's often what the struggle, the accountability of the individual, but also a sense of shared responsibility and teamwork problem solving. What we do need to do is making sure that everyone feels comfortable contributing, taking initiative, and learning from each other. And that's not always as simple. So what is the perfect macrons? And then I will give to Petra, because she will go a lot more elegantly into the detail. I do think, at the end of the day, we have a lot of people in the team, and sometimes the owners are forgotten in this team. So we have quite a few people to improve the patient care, especially in small animal. I'm only talking about small animal now. But so, how do we get people to communicate more effectively, leadership abilities, collaborative learning, room for innovation, room for making mistakes safely, sharing the knowledge, and having obviously a growth mindset. And now I give to Petra to go into the real depth, and I take my off the screen. Petra.
Thank you, Holger. And I would say that I don't know why people would hate you for the growth mindset. I think the growth mindset is really, really helpful for sure. I did see one of the comments asking for the Mentimeter code again, so I'm not sure whether that's something you could.
Yeah, I can definitely, on the next Menti question, I can give the code again. Yeah.
Great. Okay. So I'm going to talk a little bit about psychological safety. I did also notice a comment on emotional resilience. Somebody was asking about emotional resilience, where we sit with that. And I'm not specifically going to talk about, I'm going to talk about emotional aspects, but not really emotional resilience. But anyway, we can discuss that right at the end. So first of all, the question is, what is psychological safety? And perhaps just tucking in from the back of what Holger said, psychological safety is basically the incubator, and that is the one ingredient that we need to create this environment where this learning feels safe and where that stretching is possible. So the question is, what is it? What's the definition? There are different definitions about, but I think Amy Edmondson is a good person to go to, because she has researched psychological safety extensively, particularly also in healthcare environments. And this is very relevant to us, of course, as a veterinary profession. So in her words, psychological safety is the shared belief held by members of a team that the team is safe for interpersonal risk taking. So it is a belief that's collectively bought in. So members of a team collectively believe that this is true and that it's okay to take interpersonal risks. So then you might ask, well, what are interpersonal risks, and how safe can it be to take a risk in the first place? Because a risk obviously always means there's some degree of uncertainty about outcome. So what we can, in the second quote, that sort of relates a little bit to what that interpersonal risk might look like. So people who feel psychologically safe are confident that candor and vulnerability are welcome in their workplace. And with candor, we can, the definition of candor, basically, candor means honest and direct communication. which doesn't mean that it's not kind. It just means I am directly approaching you and I'm talking directly about what matters. Vulnerability could be explained as sharing my inner thought processes or what's going on inside me. That might be thoughts, that might be feelings, it might be needs that I express. So that those two things are basically actively welcome in the workplace, and that they believe that will not be punished or humiliated. I'm not a primary English speaker, and every now and then it shows. Speaking up with ideas, questions, concerns, or mistakes. So if I could have the next slide, please, Holger. And this basically means that even though a risk remains, I do apologize. I need to just switch off my, not sure why the notifications are still on. Even though interpersonal risk, there will always be a risk remaining, but we basically feel that the risk is so low that we don't get into a fearful state. And I love this quote because it relates really nicely to the title of this webinar. If I could have the next slide, please. I think what's really important is to also get a really good understanding of what psychological safety is not. And Holger, you shared the nice slide with a ballerina, and the sort of what we're not doing with psychological safety. And I think this is important to understand. What we're not doing is to just stick to the green comfort zone. As I said, it is about risk taking. It's about calculated risk taking, I suppose. And the point here is that psychological safety can help us to go into that growth zone. Well, we feel a degree of discomfort, and that's why psychological safety is not absence of discomfort. It is absence of fear or a low degree of anxiety at the most, but we really definitely not fear. So we've got an absence of fear, but that doesn't mean that discomfort is absent. Psychological safety is also not just pure trust. We do need trust. There's no psychological safety without trust, but you can have trust without psychological safety. Yeah. Psychological safety is also not brutal honesty, and is also not just being kind, because we can be kind without honesty, and that is not helpful either. Some of you might be familiar with the concept of radical candor. And there you've got the ruinous empathy in one corner, and then the brutal honesty. So what you're basically doing is you're combining kindness with candor, with honesty, and then you're able to talk about what matters, but in a way that feels less risky, and that is okay to talk about. Psychological safety, and that's a really important point, I think. Psychological safety is also not the same as emotional safety. Emotional safety relates to sort of a visceral, embodied sense of I'm safe. And safety and security are associated with psychological safety, and hopefully in a psychological safe environment, I would argue you would feel emotionally safe most of the time. But there might be situations where you are just going towards the edge. So it's basically not being always in the green comfort zone. That's what I'm trying to say. Next slide, please.
So we have another mentee. I thought it was really great. Now let's see. Why do you guys think psychological safety is important? I really like this, Petra, what you just said. You know, it is because it's actually not kind, in my opinion, if you don't give honest feedback. Because I think we always, because kind is not nice, no? So at least in my opinion, I'm not sure what you think.
I think, well, if there's one thing I've learned, then it is that different people mean different things when they use different words and different terms. Yeah. So I think it's just very important when we say that, what do we mean by it? And I do think that just being, you can have a superficial degree of kindness or niceness that is not necessarily kind in the long run. And as a parent, I mean, I'm not a parent, but it's sort of, I think we can probably, I'm not quite sure whether people are being shy, but there's nothing you can do
I'm
wrong
not sure
here.
either. So if people want to, because I know that people have been very good in giving comments below. Oh, fantastic.
Wonderful. Well
Yeah,
done.
there is a little bit, this is a challenge. There's always a little bit of delay by streaming live, but that's how life is, you know. We always delay. But just for the other guys, because you asked earlier, it's dementi.com you have to type in, and then it's the code 71231965 at the top of the slide. So one person is at least brave enough to say
Yes.
enable learning.
Well done. And probably the thing to say here is that this is, we're aiming this to be a collaborative learning environment. So there's really no risk here, I would say, because it's well, it is safe. We are all in good company and good community. So hopefully we can learn together. And even if an answer is different, and legitimately, I think there can be different viewpoints and different emphasis and different experiences. So,
now they're coming. So, you know,
Brilliant.
I think this is an interesting comment. Improvement of internal processes allowed by honest conversation without the fear of being judged. We are always constantly being feared. No, we come still to this. I don't know how your education was, but the teacher's pupil situation or the parent, you know, son situation. Yeah. Oh, now look at that. Great comments.
Yeah.
Builds trust, innovation, teamwork, improve in job performance, happiness. Yeah.
Well, to be able to show insecurities, yes, absolutely, and enhance patient care, preserve patient and co-worker physical safety. Yes, physical safety is important as well, absolutely, and that's been shown that it's tightly associated with psychological safety. Openness about own limitations, very important. And we had the first building enables learning, builds trust, innovation, teamwork, and improve in job and performance happiness. At work, I think, probably. Wonderful. Well, thank you so much for these really great insights. And I think that is, we've got more. Safety, improvement of welfare, be confident when I make decisions, trust, improved self-awareness. First, we absolutely assume that psychological safety is important. I think that it's still needed to be determined. Here's my view. However, being allowed to learn and make mistakes promotes growth. Yes, I agree.
Fantastic. Yeah, I think really great, and obviously for all members of the team, right?
Yes.
Great. So I think we move on because I think you have a lot of more slides. So
Yes.
Why is it important for you? Was there something you didn't mention on your slide? Is there something different?
No, well, I think we've got pretty much a nice complete roundup. Everything that was mentioned, I think, in one way or another is on here. And psychological safety has been heavily researched. It has been, and there's loads and loads and loads of evidence that it is important for many, many desired outcomes. Here, particularly, we're going to focus on patient safety and learning, which are here on kind of at 9 o'clock and 3 o'clock on the clock face analogy. But many people have mentioned other ones. There's actually also an association with business outcomes in the long run. So a huge different variety of things. So thank you.
And there's a great comment from Tristan. Hi, Tristan. It's great to have you here. That's always good. I hope you're well. So he says, interesting how comments can be grouped into two categories. Psychological safety can improve organization or benefit individuals or both. So
yes.
Very good point.
Yes, it's a very, very good observation as well.
So I'm now looking forward to this slide because we actually didn't practice this. So I'm looking how you boost my little brain.
So this is just really the way I look at psychological safety is a little bit like applied neuroscience or applied neurobiology, because in a way what we do know is that and this is another quote by Amy Edmondson from her book, The Fearless Organization, which I really love. I can just recommend to read it. That brain science has amply demonstrated that fear inhibits learning and cooperation. And before somebody says, oh, but hang on, why do we have electric fences and why do we kind of sometimes see some effects with punitive methods? Yes, you can get compliance with that. And in some specific environments, it might even work. So often Amy Edmondson speaks about it. If you were sort of in an industrial situation, then in the old days, there was this carrot and stick approach. And yes, you might get some results. However, as you mentioned already, Holger, we work in a complex environment. Veterinary medicine is a complex environment. We need to make complex decisions. We need to make decisions collaboratively, and we need to work together. What happens when we experience fear? And this is really, this is a brain, obviously human brain, and we can broadly organize it into three broad areas. So we've got the thinking part of the brain, which is particularly in the prefrontal cortex, right at the front, where we do problem solving, where we do logical reasoning, also moral decision making, and also sort of decisions whether to collaborate or not, those kind of things. We then have the more emotional side of the brain, and broadly speaking, that is more sort of hippocampus and amygdala, but there's also other areas, and this is obviously simplifying and reducing it a little bit. But basically, when the amygdala, which is an area in the brain which is therefore emotional memories, processing emotional memories and processing, that can hijack the prefrontal cortex. There is a mechanism by which the amygdala downregulates the function of the prefrontal cortex, and then we cannot think as well as we could.
Yeah, the freezing type behaviors. So,
it's precisely that, and there's ample of evidence also from human medicine how incivility, for example, and even sometimes quite low-grade threatening or ambivalent behaviors where we're not quite sure, oh, how was that meant? That can reduce our cognitive bandwidth already significantly, and that's basically the science behind it.
Yeah, and what I really like on this, obviously being a little bit of a neurologist, is that yes, punishment or your electric fence will obviously give you avoidance behavior, but what we want to have is not avoidance behavior. We want to train people. Just because someone shuts up doesn't mean that he actually understood what you're saying, and it shows you how important the limbic system is. And what you said earlier about psychological safety, to give the emotional background to be actually able to learn, to be open to come into the consciousness, no? Because the limbic system is unconscious and then the neocortex is consciousness, and shows you how important it is that they feel psychological safe. Otherwise, they will not be able to learn. It's just a mechanism of the brain. The brain will shut down, right? And it's very nicely demonstrated here.
That's why I love giving this with a neurologist, because you'll get the complementary.
Yeah, and the interesting thing, so just a fun fact, Albert Einstein, he said you only use 10% of your brain, right? And Schweitzer said it as well. But, at the end of the day, he was wrong. 10% might be the part where you make conscious decisions, but then there is 90% which are unconscious. And we always need to think about this. Many of the decisions we make or how we feel are not logic. Most of our decisions are not logic, right? So yeah, fantastic. Yeah. So I'm not sure if we need to do a first Q&A session, because unless people want to already have a question, and the hello was from me because I was teasing Petra earlier. So if you have any questions at this stage, or otherwise you put it into your comments, then we can pick it up now.
Perhaps we could ask Julie as well, whether she's picked up anything sort of really relevant.
So far, you guys are fielding it really well. I know that there was a question about where to comment. So I think that's probably been cleared up. And
we
then
have so many areas to comment now.
yeah, there was also a comment. Somebody's drawn a parallel between your discussion, Petra, and the TV series Band of Brothers, but I'm not sure what the specific scene was. So that might
That'll be interesting.
here it is. The overall growth of the people that series covered, despite severe external stress. So anyone who doesn't know about that series, it's actually an HBO series about Easy Company, which is an American paratroopers company that was sent in the night before D-Day behind enemy lines. So definitely extreme stress, as anyone in that situation. But it chronicles a lot of their journey. So also in their training phases before they were put into France. So very good point. Thank you, PetVet, for sharing.
Yeah, and I know the series, and there's also, it's really interesting because you can there is a bit in the before they're deployed. There is also a thing around what a not psychological safe military environment is, and there was one I don't know, one of the seniors was not particularly helpful.
And he mentioned training because I think it's very important for him. It's not the combat; it's in training. That's just to clarify. So he or she feels happy. Fantastic, good, fantastic. Then I would say we move on. Petra, is it okay?
Yes, sounds good. We've still got a lot to cover, I think. So
yeah. So I was promising you guys a little bit about the Aero culture, and like I said, this is just a great team, and I saw that Christine Kleinsorgen is also on here, and she's just shared this paper, and I just thought, like, unbelievable, and this just came out. It's obviously most of the literature we have is actually not in postgraduate training. We have a lot more in undergraduate training, right? I just highlighted a couple of. So it was about looking about a veterinary student's perception of patient safety culture. When you look at what the students said, what they get training in, then they were quite okay in the communication bit, what at least they got training in, but they have no training in human factors or safety culture. And when they were ranking in the table, and you can look at the original paper and take a bit more time to read it, but I really loved that paper. So thank you for Christine for sharing that. But you can see that even the most, in the first line, even the most experienced and competent veterinary professionals make errors. It's just a fact. And when I was thinking about which case I choose, I give you another example which really stuck to my mind when I read this. We recently, because of various reasons, I do backups on emergency in neurology, and I came in straightforward case, a DAXI, had an invertible disc extrusion, very simple. I went in there and I couldn't find anything. And I thought, like, wow, why couldn't I find anything? And then suddenly you think, like, oh, something is wrong. Something I've done wrong. What did I do? And then I realized, and this will now delight you, Petra, and this is, I think, like 6-7 weeks ago. And what happened was that the MRI, the person who did run the MRI, there's a way how you make sure that left is left and right is right. So actually, it was the opposite. And I tell my residents, all of them, they have heard it at least once, always look where the spleen is to make sure that, you never know, especially on the emergency. But no, what I did, I had it nicely collimated, only the areas of interest, didn't look at the whole picture. So it can easily happen. But what do you do about it? So I could have reacted in kind of the traditional way how I was taught, that I would have yelled at the people who did run, you know, the MRI and da 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 da. No, what we did is we looked at all the factors and looked back, and now we have a system in place so this doesn't happen again, right? Because before I never thought it would ever happen, so it was not on my mind. So I hope you understand. So everyone, and I have done a lot of taxis in my life, but I guess nowadays I do more French bulldogs. Yeah, but if you look at the other parts, it's all about, you know, patient safety and so on. It's really, really interesting for me. Read this paper, I can only imagine. And what we did with the error culture, we took really a multi-level and multi-stakeholder approach. Because when you look at medical errors, it's not just the vet. There are interns, residents, there are students, there are actually the animal owners or pet parent, whatever term you like to use nowadays, the receptionist, the enabling staff, all of them play a role. And we wanted to understand, what do you think a medical error means for you? Have you experienced, and so on? And it would be at least 2-3 hours, and I'm happy to do this, to give all the research together with my great collaborators, because we looked every stakeholders what they found important. But let's look at the vets. And when we did two things, the one publication was a typical semi-quantitative, quantitative survey study, and the other one was a qualitative, which I know veterinary medicine always struggles with, where we actually did interviews and then looked at common themes and looked if we can validate our quantitative research. And the bottom line was for owners was that what they felt when a medical error happened, they felt helpless, uncertainty was there, they had concerns and fear. It was often they had anger, frustration, and disappointment. And the very interesting thing is, and we looked at this now also from different levels of your veterinary team, and as if you're like a department chair or the clinic director, you will have a very different perception than the people actually in the trenches, right? But the one thing owners really didn't care about was money. And if I would ask any vet, everyone would say, "Oh, it's about money." No, it's not about money. And actually, it was very simple to fix when you listen to them. It was about them they wanted to have someone who feels accountable, takes responsibility for what has happened, and that it doesn't happen to another animal, and that they are empathetic. And that is the whole thing. And having dealt with owners' complaints, I can definitely agree with that. That's what they often, yes, money is a mean to a little bit, you know, smooth the edges, but that's not the primary thing. So when you ask the vets and how have you ever made a mistake that resulted in the death or permanent injury of an animal, then 80%, and the interesting, like I said, I can't show you the whole data set, but it was experienced vets or very young vets. And in the first couple of years, there was the highest incidence that people felt really, and that can show you how insecure they are. So when they have made mistakes, it often happens already in the first 3 years, and it can be very damaging to your control. And Claudia was a great veterinary ophthalmologist. We're really lucky to have her, and she always told a story where it happens to her, and you know, and it all happened to us. We all had this experience, and how do you deal with that? That's not an easy thing to do. When you look at, again, for the vets, for medical error reporting, where are the areas? It's very common across the theme. You'll find this also in the literature from other people. So diagnosis, medication, surgery are always the top list. Anesthesia, complications, or communications with owners, right? When you look at medical error reporting as a supervisors, and that's interesting, then they think, oh, most problems are communications with owners and the invoices, right? So a little bit of a different, the billing. I mean, it's definitely how I feel sometimes. And then diagnosis, medication, and the process of appointment, because they are frustrated. So depending where you look in a veterinary team, you will get different answers. And that's the main message of this slide. When you look at veterinary nurses, because we also interviewed them, then they think, again, communication with owners, diagnosis, medication, billing, because that's what they do. They realize, and the vets are very bad in it, and then the appointment processes. And that's mainly what they report, what they saw, right? When you ask the nurses what they experienced themselves, where they made mistakes, it's billing, because that's obviously one of their tasks, especially in certain countries. Appointment process, because they stand sometimes in the front and get all the negative feedback when it doesn't happen promptly and the vet is not appearing. The animal handling, so being bitten and so on. Communication about patients, and communications with owner. And Christine is also in here, Kleinsorgen, great educationist at the THO. And, you know, when we looked at all the stakeholders, the same for students, the same for vets, nurses, the owners, it's always around communication, empathy, and accountability. So it's really interesting. So how to deal with medical errors? We asked it to the vets, and most of them will discuss it one-to-one. So they will have a one-to-one discussion with someone. This happened to me, and I think we all can probably echo that ourselves. Who did they discuss it with? Colleagues is the majorities, half of them with friends or families, and only, and listen guys, yeah, because I know that a lot of supervisors are sitting here today, only a third will discuss it with you. So the question is, why don't they don't talk about it? And we have an anonymous critical incident reporting, and still people still are often scared to report those errors, but only if we have them, we can really learn from them. And 30% discuss them with the medical errors in the team. So it's actually quite a small proportion. And you have to know that these are German numbers, right? So it might be different in different countries, because I thought that was really shocking that only 3% of them, sorry, this is wrongly written. So 3% of them had a formal reporting system. So most people have a system, yeah, around 3/4, but a formal anonymous reporting system is very rare. Yeah, I know that some large employers nowadays have system in place, but it's still not common that people can report an error anonymously without identifying. And when we ask about error reporting in our hospital, we always ask, what's the systematic error? Not the individual errors, but always the systematic error, to make sure that we look at factors which could have prohibited, you know, for example, this little pony to be dying was very easy. We just changed the syringes and the needles so it couldn't connect. The same happened, you know, all of us had potentially when you have a central access and a feeding tube in a cat, that people give then the feed into the veins, into the bloodstream, and obviously they are very easy. You can change this, you know, make it just, you know, unconscious mind, so they can't plug it in there so it doesn't get injected. And we know for a long time that a lot of stuff has to happen before you actually will see an error or a critical incident, right? One of the things I can guarantee you when you do morbidity and mortality rules, and I'm sure many of you, because you are open, you want to listen to us, so most of you will do this, but every time, if you do it in non-blaming, everyone has psychological safety, and you just look at the temporal relationship, what happened when, and what could we have done better at each step, you will always see it's very different than what you thought initially. However experience, you make a judgment call, you think it's that, but then you go into the meeting and that's you're like, whoa, I never thought about that. That's what's really easy to do. The NHS has a Just Culture guide. Initially, there was a no blame culture. You know, the airlines had a system in place where it was a no blame, but then they realized there needs to be accountability. So you have to follow certain SOPs, you have to follow guidelines. That is important. And what do we do in our hospital? And I'm sure different people have different systems, but we do a multi-level feedback systems to get a kind of a temperature of how well things are. And yes, we deal with complaints, but if you only deal with complaints and you think about your hospital and you think all the errors which are in complaints is the reflection, you are subpar with your approach, because we also do like owner feedback surveys, and you will realize that most hospitals, they will have very high satisfaction because we have a very caring profession. So making sure that you see the positive, because it's always so much easier to strength a strength than to weaken a weakness, right? It's so much easier. But you need both, right? And then we have a anonymous critical incident reporting system where people should report when an error happens. And it's really difficult also to happen at the QMH as well as in TIHO, that people start putting in near misses, right? And you really have to constantly engage with them and do this. And sometimes it gets a little bit abused, the system, but I think that's just how things are, right? And then you need to work it up. Morbidity, mortality rounds, do some observations, sometimes sitting beside, seeing what happens, how is the communication. Really useful. Doing some clear audits, and then having team discussions about patient safety and integrating into daily. And yes, this takes time. Yes, you can't do it every day, but even if you do one case a week, when you have a conversation, that can really foster relationship, and everyone comes together as a human, and everyone can grow and learn. So, Peter, now you got my emotions up, right? And I'm going into the darkness in the little room here. But I hope there was something new for you as well.
Well, there always is, and that's the lovely thing. I think things like opportunities like this always great. I was really interested and fascinated by the flow chart, the emotional sort of flow chart, and what owners' expectations and their wishes were after mistakes. So yes, thank you. And would be I need to look up that study for sure. So we're now going to dive a little bit into learning and psychological safety and why this is important. And ultimately, I think learning also underpins that whole idea behind the error culture, because we learn in groups, but we also many of us are involved in formal learning or informal learning experiences that might be in small groups or larger groups. And I think what I would like to say is that even when we're not necessarily discussing anything about live patients, that this sometimes already is experienced as a high stakes environment by the learners. So I think we have to recognize that that's sort of relating a little bit to what Holger said, that only a third of the supervisors are involved in discussions about errors. I think there is sort of just this power gradient sometimes can be really, we sometimes underestimate that because we think as seniors we're approachable, but
exactly, yeah, we are nice people, right? Yeah.
So what's the problem?
Yeah.
But I think we sometimes underestimate really what effect that power differential has. And so learning environments, even if there's nothing at stake, can be experienced subjectively by learners as a high stake, because it's that judgment. We are sometimes then when interns and residents are around, it's about career progression as well. So I think there's just loads and loads of things which are entangled in this. So if we go one further, please, Holger. And this is just a reminder that
I knew that I have to describe a radiograph now. I feel not safe.
You won't. You're right. We haven't got enough time for that. But it's just a reminder to say that even when we do imaging rounds, these are experienced as high stakes environments, because there's always an opportunity to, or at least we fear there's always an opportunity to make a fool out of ourselves. And I still remember this when I was in general practice and I was working towards the imaging certificate. I went to Bristol University for the sort of film reading there, which they had for people studying towards a certificate. And I was absolutely petrified in the film reading, even though everybody was really nice. And so I think we just need to sometimes remind ourselves as seniors that this is the case. So next slide, please.
Oh, I'm so glad.
So here is a paper which I've got some references right at the end of this presentation where you can take a screenshot, but I would really like to encourage you to have a look at this paper, which describes what happens when we're not in a psychologically self-learning environment. And what the authors describe here is that psychologically unsafe environments are characterized by feelings of anxiety, shame, and inadequacy, as well as decreased speaking, participation, expression of needs, and intention to report adverse events. So these are really important things in the veterinary environment for all the reasons that Holger just explained. We want participation, we want expression of needs, we want intention to report adverse events. And here it says that shame and humiliation specifically are deleterious in medical education. And in such environments, concerns about self-image directly inhibit learning behaviors. So I think if there has been any doubt left that we need psychological safety, I hope that this has clarified it. If we go to the next slide, please, which should be a Mentimeter. I think the question is, on the other side of the spectrum, could there be too much psychological safety? And that's a really good question. What is the view here? Do you agree? Do you not agree? How strongly do you agree? And again, there might be different legitimate viewpoints on this, because it might also depend on your definition of psychological safety. So some agree, some disagree. There's quite a lot of disagreement happening on the left side of the spectrum. There's interestingly very little in the middle. So it seems to be that the majority is sort of tending towards that there can't be too much psychological safety. There's a cluster sort of on the other side of the spectrum. So I think we haven't got any more votes, so perhaps we could move on to the next slide.
Now you convinced someone. You convinced someone. Fantastic. Okay.
So, we've got more people disagreeing.
I'm sorry, guys. This is always a bit of delay because we're streaming to multiple platforms. So it really depends which platform. There's always like a couple of seconds delay.
This is really interesting. So there seems to be quite a lot of people. It's a very broad range, but there seems to be certainly the impression that there can be too much psychological safety. So let's go to the next slide, perhaps. So I would say it depends what you define as psychological safety. So Amy Edmondson, in Amy Edmondson's sort of mental model, you cannot have enough psychological safety. She once was quoted, or there's a quote by her in her book actually, where she says, no, she doesn't believe that you can have too much psychological safety. However, she does believe that you cannot have enough discipline. And also somebody else who works in the psychological safety training situation also said, well, you can also not have enough knowledge. You can also not have enough, clarity. So there are a lot of things you cannot have. But the thing is here, Amy Edmondson sees psychological safety separate from performance standards. And there are a lot of things which feed into performance standards. And I guess accountability is also assuring these performance standards. So in Amy Edmondson's universe, you are in the learning zone when you've got high psychological safety and high performance standards. And then you end up in that learning zone where people collaborate and learn and are willing to stretch and also willing to be accountable. On the other hand, and I think this is sadly sometimes where we end up in vet med, you've got high stakes. There's the high need for high standards, and everybody often wishes to really get to them. but perhaps the psychological safety is not that high, so end up in the anxiety zone. And that is where what we discussed, for the neurophysiological reasons that we discussed, that that's unfortunately unhelpful, that anxiety zone. And there is, I would just like to share that there's another expert in psychological safety, who's Timothy Clark, who developed a model called the 4 stages of psychological safety, which I find personally very intuitively helpful. And he incorporates accountability as a part of psychological safety. So either way, no matter how you see it, psychologically, safety is not itself the issue. It is if we have incomplete psychological safety, or if we don't really if we're not at the same time really pressing towards high performance standards. I hope that makes it clear.
I absolutely, truly love this, and I have seen this before, and just on reflecting on me, definitely I went through a residency program where I thought there were quite high performance standards, but I did not really have the psychological safety. So I definitely come from the anxiety zone, learning, and then just plotting through and powering through. And then when you always want to do it better than your parents, right? That's what we always try to do. And then you sometimes go into the other extreme, and that's kind of why we started this conversation, no, Peter? Because I asked you how do you do this, and I would really like to know what other people think. That when you then obviously give them too much psychological safety, and if there is, but you don't give them enough performance standards, and you don't do the candid feedback thing, is that actually that's where we would like you to be, then you don't do them justice and don't let them grow, and I think this is a really interesting concept, and also a difficult one. So it would be really interesting to get people's thought later how you stretch them but don't overstretch them, and I don't know what your thoughts are on that.
Yeah, well, we'll come to that. And I think just very briefly saying, you can pop up the next slide, please. Just reminding also about the candor, about the need for honesty. And that, I think, is important here as well. So psychological safety, and we brought up the comfort zone and the growth zone. I think what's important to recognize, and I alluded to that earlier, that also people might not feel the same degree of safety. They might not have the same size of the comfort zone. They might not have the same size of the growth zone. And I think as a veterinary profession, we are very good to not let people see how it's actually looking inside us most of the time. And I bet you, Holger, that your supervisors would have had no idea that you were in the anxiety zone. So, and I think we see that a lot. And this is what part of the reason why we're having this conversation now, and why I think it's important to have these conversations. So how it's really difficult to know how other people feel inside. And also my comfort zones might change throughout the week, throughout the month, depending on context, depending on the task I'm facing. So if we go to the next slide, please. I don't want to spend much time here because I think we're running a little bit short. I just want to leave you with this great quote by Tom Garacti, who's another psychological safety nerd. And he says that psychological safety is not a level playing field. A team is only as safe as the least safe person. Because remember, it's a shared belief. So if one team member doesn't believe it, it's not a truly psychologically safe environment. And it is difficult because there's loads of power gradients. So not only formal hierarchy, but also the sort of power gradients that come into vet meds through society. So we've got obviously privilege and marginalization, and that plays into that as well. So if we go to the next slide, please. So this is a Mentimeter question. And this is your opportunity to share. When you think back to the best training sessions ever, what made it so great? Was there something, perhaps just one or two words? We want to make this, I would really be interested in your views. And I'm not sure, Holger, whether we would have access to this afterwards if people need to think a little bit about it.
100%. I mean, it's all recorded. You know,
Yeah.
it's obviously on LinkedIn. It will be recorded on YouTube. We will make snippets, so it's all there. Yeah.
I mean, this Mentimeter slides, the results.
Yeah, and we get them as well.
We get them as well. Okay. Well, it was safe to learn by mistake. Okay. Yeah, I love that, because this is exactly what we're talking about today, isn't it? So a learning environment is great, and experience is great when it's safe enough to make mistakes, when your mentor takes time to work down to your level. Yes. And this goes down to having an understanding and having sharing information in a way that is digestible and understood. So as we said, you cannot have too high psychological safety, but you might have a lot of lack of clarity. And then that is where the performance standards might be tricky, because we're not talking about the same thing. We're not on the same page. So perhaps we could leave it at this. So thank you for your contribution. I'm not sure whether there's anything else coming.
Yeah,
but
might always be. There's also some comments. I'm not sure if you have seen them as well. Oh, there's more.
I see a comment by Lewis about the restorative just culture. And I think this is a really, really good point, Lewis. And I would like to actually, the accountability piece is also there. So in a just restorative culture, essentially what happens is that accountability is looked at something that you do prospectively. So an event happens, that harm has happened. So what you do in that sort of cultural environment is that you notice that harm has happened, you establish the needs of whoever has been harmed, you establish who's been harmed and what their needs are, and then collectively you decide whose responsibility is to meet the needs. And then collectively you work on a forward prospective accountability. So how can we make sure that this does not happen again? And this is how organizational learning and team learning happens. So we had some more points here. Supportive
and some
practice.
candid feedback. No, excellent mentor who was strict, but always explained why he criticized one and how this was important for one to grow.
Yeah.
Yeah. Just be clear of why you do it. Yeah.
Yeah. Enthusiasm and passionate about communication and supporting learning, sharing ideas independently, supportive practice.
Yeah. All great points, no?
Yeah, really great points. So thank you. So what I would like to do now, we haven't got much time left. So I'm going to, but the slides are going to be available post-event as well. And I also want to say that I haven't got all the answers. This is just really a very broad guide to what we might do. And other people might also have other perspectives, and that's also fine. Psychological safety can look very different in different teams, can look very different in different cultural settings. So what might be perfectly psychological safe in, I'm just picking it out, in German culture, broadly, maybe
nothing is safe in German culture. Yeah.
Maybe different, or even a psychologically safe German culture might look different to a psychological safe average UK culture. And also in individual teams, it might look very, very different. So I think that's just an important thing to notice. So Amy Edmondson has got this simple model of connect and frame, invite participation, and respond constructively. And I would just like to walk through how that might look in a veterinary environment. So, or just generally in a learning environment. Next slide, please. So connecting and framing means that either as a supervisor in general, we can do that as a general thing, or we can do that even in a shorter version at the beginning of a training session or a workshop or whatever we're doing. Most importantly, we relate to the people on a human level. What we try to do is we try to reduce the power distance. We try to ideally use first names. We try to kind of make away with our formal hierarchical job roles. We're just checking in with everybody. How's everybody feeling? If we don't know everybody, really important to check in with names, make sure that you as the most senior person, that people know who you are and what you're there to do rather than your job role. What can also be really helpful for supervisors or people who mentor people or who have a longer relationship is to check in with them. What brings out the best people? What do you need to learn at your best? What do you need to work at your best? What's the sort of communication style? Have you got any particular needs? What do you like? What are your likes and your dislikes? So that can be really helpful to explore. And it's really helpful to do that prospectively before we get into a high stakes situation. Thank you. Next one. So particularly have a conversation. So this is also called a social contract. So discuss that from both sides. I might also have needs as a supervisor. I might have a certain style of communicating. It can be really helpful just for the people who you train to know that this is how I tend to do things. However, I have had feedback that this can sometimes come across as a bit strict or as a bit this. So if that is the case, please tell me. So can we have a bi-directional discussion around this and agree on how we're going to deal with this, and also agree with perhaps how are we going to agree when we disagree? How can we kind of have a conversation around how we improve things when things perhaps have gone less well? And we can expand that to a team, and then we make a team agreement. Again, psychological safety is a shared belief of a team. So having conversations around this. And yes, to a point of Holger, this does take time. But if we invest that time, we will save so much time with actually less complaints, potentially less quibbles in the team. We'll have more straightforward conversations. We will save so much time in the long run. Next slide, please. So these are just a few phrases that we might use to frame a learning event. So perhaps just say, just to let you know, to give you a heads up, I will ask you for your thoughts and ideas. And also say this is an opportunity to learn. Just remind people it's okay to make mistakes. It's okay not to know. And that mistakes are there to learn. So just reminder for that growth mindset. Next slide, please. Invite participation. So what can we do to do that? So when we're in that situation, just invite everybody. And there might be some people who might be more quiet, and but some people actually, we know that we've got a lot of neurodivergent individuals in our profession. So it's important to respect individual conversation styles. But if you had that conversation at the start, then people will actually be happier to contribute. And also you might know that somebody may be introverted and they might need a little bit more time to kind of just form their thoughts. And you might not necessarily then put them on the spot every time as the first person. Ask to build knowledge, not to expose knowledge gaps. So this is about connecting dots and not exposing the gap between the dots. It's helping people to connect the dots. And not to kind of put them on the spot too much. And share your own mistakes. So if we go to the next slide, that might look like, for example, if somebody gets stuck in a film reading, what you could do potentially is to say, well, look, this is a mistake I made in a similar case, or this is an area that I overlooked in a case before. So what could we do differently? Or what do you think about this structure here? Is there something that would be helpful for me to share right now? But it's sort of different ways of open questions that might help to kind of just instigate discussion. Next slide, please. And this is really important. And I wonder whether you'd want just to chip in with the 3 R's. Which you didn't mention earlier.
Yeah. I mean, when we had obviously a little chat before, and I said to Petra, it reminds me a little bit of how to educate children, right? And there's a 3R principle, and I find this really useful. The first R is about regulate. You know, something happens, you regulate, then you relate, and then you reason. And I think what most parents naturally do is they regulate and then they try to reason. It doesn't work. You can't reason. You first have to relate. And the relation part is so, so important. Otherwise, the people are not listening. Like you showed earlier, the brain, you just can't listen.
Yeah. And there is such a thing as co-regulation. So I think if somebody is really grounded and really stable, ideally the supervisor, then you can help the other person to actually become more regulated again. So that can happen. And so responding constructively is exactly that. So when we get bad news or when something doesn't go the way we want it, self-regulation, first of all, is really important. And this is, for me, a learning trajectory for life, I can tell you now. And it's okay to get that wrong as well. I mean, at the end of the day, we can always apologize in the end. But what this is about is it's about figuring out, how does this look for the other person? Why are they seeing this so differently to me? And finding that out in a way that feels safe to explore that question. Next slide, please. And those people who know me and have already made the reference to Ted Lasso, honestly, watch it. The one thing I always want to do is to have, I think we need to have a leadership course in VetMed based on Ted Lasso. It will all become clear when you watch it. So basically, he symbolizes the be curious, not judgmental theme. So responding constructively means saying things like, can you help me to understand what led you to the conclusion? And remember also, what we say is one thing, but how we say it is another thing. So there's body language, there's the tone of voice, and the way how we intonate things. So that's another thing to be mindful of. Perhaps thank you for sharing your view. I would like to understand a bit more what you meant when you said this and that. So just finding ways to not say, oh, why did you do it this way? But actually just kind of find out first what's going on for the other person. So next slide, please. And that should be the last one, I think. So responding constructively in the long run also means providing actionable feedback. So be very specific about what people might do better. And you're obviously the instructor at the bottom, then you can tell them how to do the rock climbing better. And this is similar to VetMed. And recommend learning strategies and reference sources. And of course, it also depends. Again, people have different learning strategies. So what works for one person might not work for another. But broadly, I think it can be helpful to just share what has worked for us. And then it's up to the others whether it works for them or not. So just a few tips. I think that's it. I think there might be just a reference slide.
I think we have another Menti meter.
Oh, yeah, we can use this as the sort of yeah, whether you guys have got any phrases or behaviors that you've found helpful to connect with others and to invite contributions, or responding to the viewpoints of other people or mistakes. I'm not sure. And we can wrap that up in the last Q&A as well. I'm not sure how you would like to play
we can
that.
definitely do that. Why don't we add this to the Q&A and then here are your references, and then have some final discussions, right?
I think there were 3 points in. I don't know if you have access to the Menti, because I think there were 3 comments.
Yeah, I can go back if you want to.
No. Optical illusion. We go back.
We go to the last because I think there's a lot of questions. We definitely need to go back also and look at the comments. I mean, people have been very active, so I'm looking forward to see how Julie summarized this to us, because I saw that she was writing as well.
And just checking in on time. Sorry, Olga.
Yeah, I think we have another 5-8 minutes or so, no?
Yeah, I mean, I would be personally, I'm happy to go a bit over, but I obviously want to also respect other people's time. So I don't know.
Yeah, we can't go over 2 hours because LinkedIn doesn't allow it, but that's
No,
otherwise.
I think
it's
2
good.
hours is excessive, but we
I
can
think so
do another 10 minutes.
I think so too. I think so too. But I think there have been, I mean, I loved a lot of the comments I read. Let me add me to the stage because I'm actually double here. So I really scary, really scary. I have 2 computers side by side. Yeah. And now Julie is laughing. So I put Julie on the spot as well. So what I will do is I think what we can do is have a little chit chat. And I remove, I have 3 personalities tonight, so I remove one of me.
So one of the questions that I'm sure they would love to hear your perspectives on is coming from PetVet72, who asks, how do you guys deal with a situation where there is a complication, but the cause is unknown? Who is the first suspect? Resident, student, tech?
That's probably to you, Holger. I think you're muted on that particular computer, so you might need to unmute yourself.
So now you have to see me double. So that's up to you guys. You all were drinking too much alcohol when we were talking about. Sorry, it's just how it is. Yeah. And you don't know how resilient and the training I just had. So, okay. I think it's very difficult to always know, but if you have a systematic approach, and I actually use an approach which I've done also for court cases. I always go with a temporal relationship. So what was the first thing, what happened? And then we just go one step after the other. And we ask everyone what they could have done better. And suddenly people will start talking about if there was something they learned. And you have to, I mean, when we start with the mobility mortality rounds, definitely in Hanover, it was, you really have to be careful that people are not judgmental. And often it's the people who are more experienced, they kind of, because your decision making is really fast, but sometimes because a lot of your competence is unconscious, you also make mistakes because you do a lot of pattern recognition, and you have to actually stop and then look at the system and really logically think through it. Otherwise, you don't have an open, because they will always look up to you because you have the answers. So I think it's really important to make it systematically, and make and that people learn that it's a framework, right? Where you can go back to deal with errors when they happened. I think that's probably one of the tips. Yeah. Julie.
Yeah, we have another question from Tristan. How do you reconcile the concept of psychological safety and accountability of one person where the buck may fall if we consider that this is what owners want, i.e., a responsible individual where the error originated?
So I think it's probably going back to psychological safety, what psychological safety is. Psychological safety is the shared belief of a team that it's okay to take interpersonal risks. So I think, to me, in a psychologically safe environment, and also coming back to what Lewis shared about the restorative just culture, it does not mean that we haven't got a person who takes responsibility for something, but it is done in the understanding that that there has been a mistake in good faith, that somebody has made an error that was not intentional.
Exactly. Yeah.
And then, and that I think, and I think that there's a lot of actually what the data that Holger shared very much also goes to that owner want an answer, and they want to make sure that it doesn't happen again. They don't necessarily want that the person who's done it is punished in a way. That what they want is a learning outcome, I think. So that doesn't mean that I cannot take responsibility for the error that I've made. And it doesn't mean that collectively we can't have accountability for this not happening again. it's just important that this is done in a way, because we also know that error is, and the statistics that Holger shared with 80% of people making an error that led to the death of an animal, of a patient,
or harm, yeah.
or harm, or high level harm. This feeds into burnout. This is a high emotional drain. It has got an effect on confidence levels. And it's really important that we, and Luis Santos, he's done a lot of work on the second victim, which we haven't sort of formally named, I think, in this webinar today, but this has got impact on carers who've made these mistakes. So I think we need to, and what, as a profession, what I would love to do is to work towards a culture where these events are recognized as something that can happen to anyone. And we try to deal with them collectively and in a compassionate way. And I'm sure that pet owners would generally resonate with that if that is explained and communicated in that way.
Yeah, and I might say it now wrongly, but one of my students who was doing the aeroculture work, she had a really good metaphor, comparing again to pilot, looking at how many errors happen in medical field, and she said it would be like, you know, like an airplane crashing every single day. And guess what would happen in society if that would happen, right? So meaning that if we could show that actually by doing that you can really make a game shifter for the patients, then I think everyone would totally agree with it. But one has to be brave. And there's a really good comment, you know, that obviously even if you know there's a mistake, you know, here was about a social complication because of material failure. The shitstorm you get, and also on social media, can be quite extensive, and the damage. But if you have a framework, at least you can work it through, because I think not knowing a reason makes you even more easily being harmed. But I can totally see the aftermath. But you know, what about a world where we would have a central registry and where people could mention what has happened, and then there would be a workup, and then we would suddenly show that we have a decrease and improvement in care? I think they would all embark on it. And I do think when you look at error cultures, and it's in small animals, we have it actually quite simple. But if you, like Julie, do horses, and you have 1 million you know, pound horse or whatever, euro horse on the table, and then you say, oh, look here, I did the mistake, and then it comes another dimension, because it's also a lot of money involved. And I know in human medicine, often as soon the insurance system or the lawyers get involved, they don't say, you know, you are not allowed to talk anymore, However, people go then in front of the court because they fear no resolution, right? Normally you can, if you get people in a room, and most people, you sit them down, you listen to really what they need, and you are and then you reflect on it. You might not at the end that they won't love you, but at least they felt listened to, right? So I think it's a, you know, I mean, not all sides will fix everything, right? So
it's complex. It's definitely complex. Yes. And I've just seen at the end here another couple of comments from Krina, that the first suspect is always the system, indeed.
Yeah.
And Emmanuel also shared some experiences from his residency where equipment actually turned out to be
exactly, that's what I mentioned.
But yeah, so I think it really makes for difficult experiences, doesn't it?
Emmanuel also posted a question looking for comments on pathological empathy.
That is interesting. So for me, to me, it's a little bit like saying pathological anger or pathological any sort of concept. So I'm not sure whether something such as pathological empathy exists. I don't think so. I think empathy in itself is a skill, and it's a human ability to take perspective, and also, so there's different types of empathy. There's cognitive empathy and there's emotional empathy. I think is what you do with it, which is the question. In fact, psychopath, and I might be wrong, I'm not a psychologist, but from what I remember is that psychopaths actually have got quite a high level of empathy. They're really good in perspective taking. But I don't necessarily want to go into the pathology of everything. What I would want to say is that it's how it is used which makes the difference. So we can use empathy in different ways, and also compassion sometimes is seen as something soft and something that's not helpful, and I think it's the way we use it that's the question. And again, different people may
I have a couple of comments here, not because you guys can't see that anymore. There were on Menti, have a sort of aware and empathetic mindset to truly understand the way the other person in the communication loop thinks is essential to improving communication, psychological safety. So I think it's a very good comment. And then I agree that finding the line between anxiety and learning zone is hard, especially when the individual learner may not know themselves. How do we encourage vulnerability to work on self-awareness? Yeah, it's totally, and I think this is an absolutely amazing comment. And actually nowadays it's also sometimes difficult because we are a lot more mental health aware to actually I mean, you then need to go through different zones to go into the learning zones. And yeah, I don't have 100% answer, but you know, the candid feedback, I guess, is one of the solutions people have been mentioning. And like I said earlier, it's not kind not to do it, because not getting feedback is also not good to know. Oh, Imke has something more, no?
Yeah, I wanted to just highlight, Petra, that you had also talked about the ruinous empathy from radical candor. And I think that probably comes back to this comment as well.
Yeah, maybe. Yes, I'm just
good stuff. No, I think I'm quite amazed how many comments, and you guys don't see what we see, but we got bombarded from every corner of comments, which is
yes,
great.
and I'm sorry, I don't think we'll be able to go through all of them. I think there's just really
but I think Julie already did some, and Kit had quite some very good statements as well. So really great to have such a great active group.
Yeah. And I think the question around emotional intelligence is really, really interesting. And I do think, and also the sort of ability to self-regulate. I do know that, again, it's something that in the human, looking at it with a human factors hat on, you were obviously discussing the sort of the airline industry and what we've learned, and there's a piece around self-regulation that can be learned as well, and you can learn certain things. But in my opinion, I think, and this is, I think, also where Holger and I were just so aligned, these skills, I think we need to put a lot more, and I think Julie as well, I can see her already smiling prospectively. I think we need to, in my opinion, put a lot more emphasis onto these human skills in veterinary medicine, because they they basically underpin the learning, the effective learning.
And to probably, and then I will shut up because it's late, but you know, we have been focusing on residency training, making sure knowledge, and we said, okay, they need to also look at clinical reasoning skill set. But the whole professionalism and, you know, the publication Christine gave me about what in veterinary students about patient safety, I mean, shouldn't it be also, you know, as higher level you get, as more specialist you are, yet you should also be more advanced in your skills of dealing and learning about these opportunities and having a higher patient safety, a higher error culture, higher professionalism, and so on and so on. So really nice. What I will do, Julie, unless Petra has some famous last word, to give you the floor, because you have a couple of slides, which I just added in the meantime.
Oh, wonderful. Well, first of all, I think that I can't thank you enough, both of you. And I think the amount of engagement we've had in this session is witness of how amazing people feel that not only your content is, but also your presentation, and how much they just wanted to be here and hear what you have to say on this vital topic. So thank you so much to both of you. We are honored and privileged to have your ambition and your willingness to work with us and your drive. So thank you. And there's no way to applaud on LinkedIn, but I think we're all applauding you in our hearts.
And thank you to everybody. Thank you.
Yeah, I also want to thank the audience for joining us and for being so participatory. That's amazing. Please do feel free to reach out and share your feedback, your ideas for future topics. You will receive an email from Eventbrite inviting you to provide feedback. And there's a few little things to keep in mind from the side of EBVS. We really want to keep the conversation going in an engaged way. So please subscribe to the LinkedIn newsletter, follow us. We're on LinkedIn, YouTube, Instagram, and Facebook. Please check out the Agriculture Medicine, Animal Medicine YouTube channel, which Holger has very well populated. And keep an eye out for an upcoming EBVS community page on LinkedIn, as well as our Congress 2.0, which should be announced for the fall of 2026 pretty soon. So lots of things coming along in the pipelines. Some well-being resources are available. So please feel free to reach out. Happy to interact. And thanks again, Holger and Petra. Any last words from your side?
Oh, just thank you, guys.
Yes, it's been amazing. And probably just for the viewers also to let you know that this actually was sparked, this webinar was sparked off at the last EBVS Congress. So next year is your opportunity. If you haven't been, it's been amazing. We'll see you there again.
Fantastic. Thank you, guys. Good night.
Thank
you. Good night. Bye.